All right. This is going to be a quick a quick PowerPoint, or at least some of the things. All right. This is part of a critical care sort of training that I have put together over the last couple of years. Um, and the first thing that it talks about is flight physiology. Okay, so although you see all of these topics, not all of those are included in this. We're just going to talk about flight physiology and everybody's favorite thing, gas laws. Now, you might not really want to hear about gas laws, but if you have the impulse to be a flight medic, gas laws are something that you have to be cognizant of. Okay, so um, I'm going to talk about that. Flight physiology, the concept of flight physiology is merely the understanding of how the combination of altitude, temperature, and other factors play a role on the patient and the patient care, but also the provider and that provider's capabilities. Okay, depending on the platform that you're using, whether it's a rotor wing or fixed wing. Okay, helicopter versus jet. Um, you're going to run into some different problems. Okay, but most of the problems that you're going to see are ascent or descent. Okay, and that can be a mild discomfort sort of thing. But when it comes down to life-threatening sort of issues, we'll talk about those as well. Now, if you are unfamiliar with gas laws, okay, here are the ones that flight physiology, or at least this, is going to talk about. Boyle's law, Charles' law, Gay-Lussac's law, Henry's, Graham's, and Dalton's. Okay, now all of them are understandable. Okay, so it's like this. Boyle's law: the pressure of a gas is inversely proportional to the volume at a constant temperature. So your memory aid is Boyle's equals balloon. Okay. Now the exterior pressure decreases as you increase altitude. Right? So what does that mean? When you go up, um, the pressure against things is going to change. Okay, assuming um, assuming your body temperature remains the same. Okay, you're going to have a change into the way that you experience pressure. Okay, so um, any air occupying thing within the body or prepared at sea level now attempts to expand unchecked. Okay, so what does that mean? Well, it means that if you have an ET cuff that is um, placed and you've got the bulb inflated, um, guess what? Now that gas is going to try to expand in that because there's less exterior pressure pushing on it, which means we're going to have to regulate the pressure of said ET bulb. Okay, and upon descending, you're going to have to re-inflate that cuff. All right, a pneumothorax. Okay, if you had a small pneumo, what's going to happen to it? Now you're going to have a huge pneumo. Pneumocephalus, air post-trauma in the cranial vault, a small inclusion of air or an air pocket now becomes greater in size, influencing the pressure on the brain. Okay, air splints. Okay, you've got to take some of the air out of those air splints as you ascend in height. If not, it's going to cause an overpressurization, perhaps a occlusion um, of blood flow. Okay, IV drips. Okay, increases rate due to gas pressure within the IV bag. So your KVO bag is no longer KVO. Balloon pumps. Okay, you're dealing with a balloon. Okay, and it's in a specific space. It's within the thoracic cavity, it's within the heart, but that balloon pump is also going to be adversely affected potentially by the fact that you're going to altitude. Okay, so Boyle's law, patient and provider assent issues. Okay, when you're going up, if you have sinus issues, okay, like a small sinus infection, expansion of those gases that are trapped in the sinuses, now you get barosinusitis. Okay, it's basically just a hell of a sinus headache and pain because that air pressure is now decreased. The air that you've trapped in those clogged sinuses attempts to expand, and you get a hell of a headache. Barodentalgia, that's just dental pain. Okay, imagine you just had a cavity filled, whatever. Okay, and there's a small little air pocket. Okay, and again, as you go to altitude, that air tries to expand, now causing you a heck of a lot of pain. Descent issues. So coming back down, barotitis media, pressure in your middle ear being in and out of equilibrium in the atmosphere. Now you got ear pain. Okay, so if you think about it, some relief if you go to the mountains and you have your ears popping. What can you do? Well, you can yawn. Okay, positive pressure mask ventilation. You can do a Valsalva maneuver. You can slow down your altitude change if you're in a transport platform for yourself. You yawn, you force a yawn, and it helps to change the pressure within the ear. So you may find some relief in that. Now, Charles' law. Okay, Charles' law is the changes in temperature, assuming a constant pressure, will cause a change in volume. Okay, Charles equals centigrade change. Now, memory tip, oxygen tanks get hot when they're being filled. If you've never filled an O2 tank, trust me, if you have ever worked with a cascade system to fill D cylinders from big M cylinders, or filling M cylinders with liquid oxygen tanks or from liquid oxygen tanks, the actual canister, the actual tank itself gets very warm. Okay, now Gay-Lussac's law, proportional relationship between temperature and pressure. A basketball left outside in the sun on a hot day, okay, it'll become tight. Okay, why? Because it was heated, the air inside of it was warmed, and just like a hot air balloon, hot air tries to expand, tries to rise. Okay, same basketball left in the same place overnight. You pick it up first thing in the morning before it's had time to warm up, and it doesn't want to bounce. Okay, your tires in the winter versus the summer. O2 cylinders register different pressures if they're left in a cold place or a cool place versus where the temperature can rise. Okay, so your D cylinder readings, depending on whether your truck is in a climate controlled environment versus left outside in the hot sun, you're actually going to see a difference in that. Okay, and that's just an example of Gay-Lussac's law. Dalton's law. Dalton's law, you can think of the Dalton gang, okay, because it is a mixed gas law. Okay, and not to get too all egg-headed and everything, but the total pressure of a gas mix is the sum of the partial pressures of all the gases within that mixture. Okay, so what does that mean to you? Okay, air's got the same mixed gases in it. Okay, oxygen, nitrogen, carbon dioxide, the whole nine. Okay, whether it's at sea level or at altitude, and at altitude, there's less pressure on those individual molecules, and therefore they're spaced further apart. So the air is thin at altitude. Okay, well, that is true. There's less pressure at altitude, so you have the same kind of gas mixture, okay, but the partial pressure or the pressure on them is now different. So you've got those individual oxygen components further and further apart. Hence, people have trouble breathing at altitude. Okay, it takes more volume of air to get in the same amount of oxygen molecules because they're spaced further apart. We become less effective as a mechanism at altitude. If you've heard of high altitude pulmonary edema, HAPE or HACE, altitude cerebral edema, that's what that is about. Okay, well, we're just not efficient at those altitudes. Graham's law, that's the law of gas diffusion. Right, it limits a gas's ability to move through a liquid. Dense gases diffuse slower than less dense gases through a liquid. So, what happens? Well, or what does this translate to? Here is gas bubbles coming out of gray matter at altitude with an open skull fracture where gray matter is exposed. So if you were transporting somebody and you were in a mountainous environment and you had to go to altitude to transport them over mountains, then you're likely to see gray matter bubbling. Okay, so if you were doing this for the FPC test, if you wanted to remember it, Graham's law, that's the one that deals with gray matter and bubbles. So anyway, Henry's law, gases dissolve or suspended in a liquid. Okay, so Henry's, you can think of Heineken. Okay, so you've got, when you look at a bottle of beer, when you look at a bottle of anything, carbonated beverage wise, you've got that gas suspended in that liquid. Okay, so when you change the pressure in that container, they're no longer suspended in that liquid. And now you've taken it from that enclosure where pressure was controlled to now atmospheric pressure. So now that's where the bubbles come from. Okay, the gases were always there, as you know, but now you get the bubbles because the gases are no longer suspended in that fluid. Okay, so when we change the pressure and bubbles become a thing, okay, that's the bends. Okay, and normally when we think of the bends or gas related problems, okay, we're thinking of depth. We're not thinking about altitude. But if you take somebody from sea level and you know that bubbles get bigger as you ascend, because that premise doesn't stop at sea level, okay? That's why previously, in previous slides, I said you'd have to take out some of the air out of the air splint. You'd have to withdraw some of the air from the syringe, the ET cuff. You'd have to do all of those things because that pneumatic pressure would not have the same influence as you went to altitude. Okay, so this is a way for you to think of it. Okay, for Boyle's law, bubbles, balloons, and barotrauma, anything air-filled, whether it be medical equipment, whether it be a device that you're using, pneumos, they're going to worsen with how altitude plays around with boils. Okay, and POPs and AGE, pulmonary overpressure syndrome, and arterial gas embolus. As you come from depth to sea level, bubbles get bigger. And that doesn't stop when we go to altitude. Those bubbles continue getting bigger. That's why if you've got somebody with a bends situation, a ground transport is most likely the most beneficial thing for them. With Dalton's, think of Dalton's gang, okay, and that's swelling of the soft tissues at altitude. Okay, Charles in charge. O2 tanks heat up when they're being charged or filled. Graham's, we got gray matter bubbling, okay, as gases are escaping from that. Okay, it's not a thin liquid, it's a thicker liquid, as in blood and CSF, and now it's bubbling at us. Okay. Henry's, think of Heineken, that's the bends, that's decompression illnesses. So when we have gas laws, it does give us some pause for math. Okay, so everybody jump in that time machine and go back to when you first learned about O2 equipment. Okay, we know about the pressure at sea level. Okay, 760 torr, 14.7 psi. Patients receiving O2 at 40%. Their FiO2 is 0.4. Okay, now what does all that mean? Well, in flight physiology or in the flight world, if you're going to take this person to altitude, you have to take these things into consideration. Okay, because you're going to have to maintain a workable, usable mixture for this patient, for their needs to be met. Okay, and the reason you're going to do that is because of the zones that you fly through. Okay, and these physiologic zones. Okay, the efficient zone is where we're at now. Okay, sea level to 10,000 feet. Okay, but even in that zone, okay, even in that zone, doing helicopter operations, heliops. Once you go above 5,000 feet, even in the safe zone, so to speak, you're going to have some ill effects. Okay, your night vision is going to be reduced. All right. When we get above 10,000 feet, okay, we're talking, we need pressurization. Okay, the aircraft itself needs to be pressurized. That's commercial aircraft. It's it's the way that we are capable of flying at higher altitudes. Okay, and the reason that is a thing, if you look at the hypoxic effects with different altitudes, you'll see that our body physiologically doesn't operate well. Okay, 10,000 to 50,000 feet, we are in the physiologically deficient zone. Okay, we need pressurization, and the concept of tuck comes into relevance. Tuck is time of useful consciousness. Okay, so how long are you going to remain conscious if something were to happen at that altitude? Kind of depends. Okay, kind of depends on how rapidly you lost pressurization. Okay, if you have a rapid decompression, okay, in aircraft, for instance, it's not going to be long before you are unconscious. Okay, the you've seen it in movies. Something happens to the aircraft, O2 masks fall. You're supposed to put that on, and the pilot's going to, get down to lower altitude, get down to 10,000 feet. This is the reason why. Okay. Now, what happens if they don't know that a decompression is taking place, that slow decompression? Then you're just going to suffer the ill effects of hypoxia over a slower period of time, and it's not as jarring as a rapid decompression that you would potentially note. Okay, so what we're dealing with there is some really bad effects. Okay, the illustration or the example that I give you at 30,000 feet. Okay, so basically cruising altitude of an airliner. Okay, if you had this rapid decompression, okay, and the mask fell and you took off your mask, okay, you'd be conscious for approximately 90 seconds. Okay, but if the aircraft were to rapidly decompress, that is cut in half. So physiologically, we just can't do anything about it, especially if it happens quickly. Okay, above 50,000 feet, you might as well be on the space station, because you're an astronaut, basically. You're up there where we can't live. Okay, it's hard enough to survive at altitudes like Everest at 29,000, close to the cruising altitude of commercial airliners. And most of the time when people go to that, they refer to it as the death zone. Slowly, physically, you're dying. Um, Now you're in an aircraft. You're transporting a patient, and all heck breaks loose. This is what you got. Okay, you can look at the hemoglobin saturation at these altitudes. The reason that people suck when they get to Mount Everest is because their hemoglobin saturation is less than 70%. That's when they get severe hypoxic symptoms. Okay, when we're above 20,000 feet, these people have to stay for months to physiologically acclimate themselves to try and make an ascent to the summit of Everest. And sometimes they don't make it. And sometimes when they make it, they don't make it back, because we're not set up physically to live there. Okay, so here's something for you to think of. Okay, if you're in the zone, if you're in an aircraft and you're cruising at altitude, you witness a sudden decompression. You got really cold temperatures, condensation, cabin and windows. The clock is now ticking, and if you don't take steps, you're going to die. Okay. Case in point, Google search Payne Stewart. When I was working in EMS a long time ago, excuse me, the county in which I work, Moore County, they hosted the U.S. Open. Okay, and that year, Payne Stewart won it. Okay, and a couple of years after that, Payne Stewart was flying from his home in Florida and going to Texas for a golf tournament. And when they got to the panhandle of Florida, where he should have taken a left, the plane did not take a left. It just kept flying straight, and nobody could get in touch with it. And yeah, so his jet continues flying in a straight line and not making contact. So military aircraft go up, intercept, and take a look. And the inside of the glass is frosted over. Okay, and what that means is they've had a decompression, and now everybody in there is dead. Okay, so they have a zombie plane, and it came down like Iowa or Idaho. I can't remember exactly where it came down, but gravity and running out of fuel, that's what brought it down. It was just flying in a straight line, on its predetermined pathway. Now, if it was a rapid decompression for whatever reason, okay, that 90 seconds is now 45 seconds. And if you're not well drilled, and if you're not very present in that moment in time, and get your oxygen mask on and do all the things, you've got 45 seconds before you black out. And that's if you're in good shape. If you have pre-existing conditions, it might be less time than that. So anyway, on that cheerful thought, let's talk about some other stress factors. Okay, with flight physiology, ambulances are hard on the body, aircraft are worse. Okay, you get a lot more noise, a lot more vibration. You have decreased levels of oxygen. You've got thermal changes as you go to altitude. You've got cumulative fatigue. You've got the barometric pressures changing, and we talked about a couple of those things, ascent versus descent, about the barosinusitis. You've got the G-force effects, lifting vertically and all that, and then it's dry. Okay, so you got decreased humidity as well. So what makes flight stress worse? The acronym for it is DEath. Okay, dehydrated, dried out drugs, like if you're on diuretics, not drugs as in, yay, let's party, but drugs as in diuretics, okay, or anything that has a diuretic property. Exhaustion, inadequate rest prior to a shift, okay, that worsens the flight stress on the body physically. Alcohol, if you think about it, alcohol is a natural diuretic, and you are cellularly dehydrated. And that is what a hangover is. Dehydration at a cellular level. And now you're going into an aircraft and you're going to altitude that has less moisture there. So anyway, tobacco. If you're a tobacco user, you are living relatively in a hypoxic state as a baseline. But also smoking, you have a reduction in night vision. Your rods and cones in your eyes don't work as effectively, and that's true about everybody, but yours to a greater extent. Okay, hyperglycemia, that's a danger for everybody. But when you're up there, can you get something to eat? No, probably not. Okay. So when all of these things, why talk about altitude? Why talk about the flight physio stuff? Well, because it's going to play into the calculus of what you're doing for your patient. Okay. When you talk about the FiO2, well, when you look at the pressure where you're at versus the pressure where you're going, you're going to have to figure this out potentially. Okay. Now, at 760 torr, at 10,000 feet, 523, at 18,000 feet, 380, you're basically at half an atmosphere. At 63,000 feet, 0 torr, you're at no atmospheres. Now, if you're flying that high, something's gone tragically wrong. Okay, but somewhere between sea level and 10K is basically where helicopters play. Right? The example of this patient, if you got them on a non-rebreather at 0.4 or FiO2 at sea level, okay, you're going to be flying to an altitude of 10K or 10,000 feet. All right, 500 torr. The oxygen requirements for that patient would be what? Well, we bring math back into play. 0.4 times 760 divided by 500, 0.61. Now you've got to go up to 41% oxygen where they were at 40% FiO2. Okay, so it does play a role. Okay, when we are working at altitude, okay, basically as we go up, the temperature drops for every 1,000 feet about 2 degrees Celsius. Okay, and that's relative. Some things, depending on meteorological conditions, could make it a much bigger change. Okay, O2 concentration doesn't change. Okay, think about the mixed gas issue. Okay, it still has the same oxygen content as far as oxygen molecules. It's just thinner. Okay, those concentrations don't change, but the partial pressures do. As that occurs, the air is also becoming drier. All right, your vision worsens, your rods and cones are affected by altitude, and smokers, you're going to have night vision issues on top of that. Now, when we're talking about altitude and things like that, altitude depends on how you approach it. MSL, mean sea level altitude as compared to the mean sea level. Okay, so right now I'm in Johnston County. We're probably a couple hundred feet above mean sea level. Okay. But most of the time, we're worried about absolute altitude in relationship to the ground, or AGL. Okay. So MSL is your altitude as compared to mean sea level. Okay. We are 5 miles above. Okay. Cool. But if you were flying in the western part of North Carolina, you would be concerned with AGL, not MSL. Okay. Um, you lift from the ground at an elevation of 2,000 MSL. Okay, so that's somewhere out west. Then you climb to a height of 900 AGL above the ground level. Okay, how high are you in MSL? You're, 2,900 feet. But if you try to descend 2,900 feet at that location because of topography, you died 2,000 feet ago. Okay, so anyway, you're going to hear mean sea level or AGL above ground level, uh, depending on the context of the conversation, if you're doing anything at altitude. Um, there are a few different hypoxias, and if you don't know that, you should, in my opinion. But the one that we deal with most of the time is hypoxic hypoxia, and there's just not enough oxygen. Decreased partial pressures of oxygen at altitude, deficiency in alveolar O2 exchange, cardiovascular pneumothorax have increased susceptibility. Now, our hypoxic hypoxia is our most common form, but we can also have the other types of hypoxia depending on the setup. Okay, like hypemic or anemic hypoxia, you've got an O2 transport breakdown. Your H&H, hematocrit and hemoglobin, less than 8 and 24, they should receive blood before being taken to altitude, okay, so that they have the components to transport that blood within the system, okay. If you've got somebody who's post-trauma and they have been bleeding quite a bit, and all they've gotten for that is LR or saline, then they're going to have O2 transport issues for that type of hypoxia. Histotoxic hypoxia, that's inhibition of O2 loading onto the RBCs. Okay, that's anything that is essentially a cellular asphyxiant. Cyanide, carbon monoxide, alcohol, nitroglycerin, sodium nitroprusside, and nipride in the wrong concentrations. An overdose of nipride converts into cyanic. Yeah, basically it turns to cyanide in your system. I'll put it that way. Okay, so now we have the inability for oxygen that may be in the patient's body to onload to the transport mechanism on the RBCs for delivery to cellular functioning. That's histotoxic hypoxia. Stagnant hypoxia, well, it's stagnant. Blood's just not pumping. Okay, so when we have reduced cardiac output, when we have high G forces, if you've seen people pass out potentially, this is one of the reasons that people can pass out with exaggerated G forces. All right, cardiogenic shock, that's an example of it. Now, some things people care about and some things they don't. Okay, and hypoxia is going to be one of those things as well. Okay, and it's all in which stage that you're in. In different stage, you can still think and function. You get a little bit of loss of your night vision due to how hypoxia affects the rods and cones in your eyes, but overall, you're still functional. Okay. In the compensatory stage, your body realizes something's wrong, and now you're trying to do more with less. So, hence the compensatory mechanisms are kicking in. increased heart rate and respirations, and now you're getting a little confused. Okay, decreased cognition. Disturbance stage, now you're acting drunk. Slurred speech, altered mental status, altered thinking. That's the level of hypoxia that you're at. And when you get to the critical stage, blackout, complete loss of consciousness, and death quickly follows. So, this is what it looks like when you're becoming hypoxic. Right? The difficult thing is spotting it in yourself. Okay, it may take team members to spot this in you. It may take you spotting this in someone else that is on the team. Okay, now imagine both of you are experiencing this simultaneously, because that is also a potential. Okay. Now the rest of this, I go into how gas pressures, at depth. Okay, so I don't think anybody really needs what my version of how to teach the bends is. But so yeah, won't worry about that. But anyway, I did want to talk to you since I had mentioned flight and critical care in the context of flight operations. I did want to talk about a little bit of the flight physiology stuff. It's a different ball of wax when it comes to doing that job at that altitude, and anyway, hopefully you learned a little something and don't feel like I robbed you of too much of your time. Questions, comments, feel free to email, and hope y'all have a good rest of your week.